Hello, good evening. We are in Mexico City at the CITIC Convention of Interventional Cardiology, and I have the pleasure of having Professor Philippe Lallier, which is an interventional cardiology of the Montreal Heart Institute in Montreal, Canada. And he's, as you know, an authority in intervention. And hello, Philippe.
Hello.
Welcome to Mexico, and thank you for being here.
You know, it's a privilege for me to be here. Very well organized.
I wanted to ask you, the imaging studies that we are having in plaque reduction, coronary plaque reduction, that started many years ago with Dr. Neeson giving high-dose statins and looking at that same place in plaque and measuring that and observing that that plaque can change and can be reduced. With more potent treatments, as we now have with the monoclonal antibodies, PCSK9 treatment, we are actually looking that in some recent trials. How can you talk to the auditorium or to this gentleman about this plaque reduction?
Right.
Is it important?
Yes, so of course the end result of any therapy needs to be reduction in clinical events, right? So in order for us to know whether plaque regression or reverse Glagov is of importance, we need to correlate this with reduction in clinical events. And it's been a struggle over the years to show this. First of all, it's been shown with QCA, believe it or not. In the very early days of QCA, there was a very strong correlation with reduction of diffuse atherosclerosis, depending on the type of measurements you made, but the scores actually showed a very good trend with regards to reduction in clinical events. This is very old data, but still the correlation between an imaging biomarker such as QCA and clinical events was kind of fairly well shown. We went further to look at the plaque itself, not only the lumen, and we found that first of all, remarkable reverse Glagov was possible in adults with mature atherosclerosis. This was something we were not sure of, but was clearly demonstrated. And we saw we have a large number of examples that we show extreme regression in the vicinity of 70% plaque regression over a number of months to years. And this is very important to know that this is actually possible, so it should be a target. Now, in addition to reducing the amount of plaque, the composition of the plaque also is important. That's not tackled by the studies that we have with IVUS, aside from maybe virtual histology, and sometimes we have other modalities such as maybe OCT and other modalities that would look at the lipid component of the plaque, such as infrared X, who has an infrared spectroscopic evaluation of the plaque showing the lipid contents. So all of these modalities work together to show an evolution of the plaque in the right direction. If you look by, for example, by OCT, you could look at cap thickness over plaque that are prone to rupture. So if you could show by a given therapy an increase in cap thickness, you could show that this is favorable and then eventually correlate this with clinical events.
First of all, what is the magnitude of the reduction? Are we looking at
Yes.
a really important magnitude in terms of imaging?
So whenever we look at regression, we look at segments of arteries, let's say 30 millimeters segments, and therefore the absolute volume that we see that is being reduced is not dramatic, but it probably does not need to be so dramatic to have a clinical impact. And so in fact, you don't expect 70% lesions to become 20% lesions. You expect the overall atherosclerotic burden to decrease by a small percentage, but the overall impact is going to be extremely good on clinical events.
And you mentioned plaque composition. What is happening in the biology of the plaque with this type of reductions? What is happening? Is it actually the lipid content is getting? Are we changing inflammation? And are we thickening the fibrotic plaque? What are we doing?
Well, it's clearly what has been demonstrated is that we can reduce the amount of lipid inside the plaque, and of course these drugs are not expected to do other things than impact specifically on the lipids. So we expect the plaque component to decrease, but our tools to measure lipid component of the plaque are not perfect. So it's kind of difficult to show a true reduction in lipid component. Nevertheless, yeah, I think we saw this in a number of smaller studies, so we have fairly good evidence that this is happening. And in addition, when you decrease the amount of lipids, you also decrease the amount of stimulus for inflammation. And therefore, it is, in all likelihood, the oxidized LDL is a very strong stimulus for inflammation. And we also see some indirect evidence of a reduction in inflammation.
Do you have any additional information in longer term, as part of your experience or part of elongation or prolongation of some of the protocols? Do we have long-term data?
Well, we have, for example, very important information regarding a sub-study or a different look at the SPIRE studies. If you look at the SPIRE studies, and Dr. Jean-Claude Tardif showed this as part of the leadership he has in this group, but he has shown that the length of exposure to these drugs, this is a PCSK9, actually has a significant impact. If you look at the patients who had only 4 months or 5 months exposure, they don't have a significant change in clinical events. Whereas those that had an average 13.6 months of exposure, they significantly started to diverge as far as the event curves are concerned. And so therefore the length of exposure is likely to be quite important. It's probably the same thing with the statins. We have seen a dramatic impact on statins, especially with statins with regard to plaque regression in statin-naive patients. So if you have a patient that has never seen a statin before, you include these patients in the progression-regression trial with IVUS, you give them a very potent statin, you're very likely to see a very strong reduction in plaque, much more so than if this patient would have been on a statin for a long term before actually being included in the study.
So we are acting in the biology of the plaque, and we, of course, have some plaque reduction and stability through LDL reduction. Do you think with additional impact in inflammation in particular, are we going to be expecting some changes in the plaque?
You know, it's been known forever that plaque is actually composed of an inflammatory component. And the inflammatory component is very likely to be involved in the clinical events, that is atherothrombosis and plaque rupture. And so therefore, we have been, for the longest time, trying to find out what we can do to decrease inflammation and control the inflammation. In all likelihood, we have had some modest success. We have shown in many studies, many phase 2 trials, positive events on biomarkers, positive impact on CRP, for example, positive impact on other inflammatory biomarkers. There are soluble biomarkers, VCAMs, ICAMs, all of these markers. But in order to see a clinical reduction in events with these drugs, we have not been able to tackle this correctly. We are currently doing a study using colchicine. Colchicine is a very old drug, but it has a distinctive approach that is much more broad on the inflammasome rather than a single focal component of the inflammatory cascade, which is of course very complex. And targeting a single focus is very difficult to expect it to work, because there are so many other mechanisms or the pathways that can be involved that we believe it's much more useful to have a broad approach on inflammation with a drug such as colchicine impacting on the inflammasome as a whole, as opposed to a single focal pathway, which has been the case in more recent years.
Okay, so it seems we're going to be heading in that correct direction in altering the biology and progression of the disease, of course, trying to lower down the main clinical events, as you just started and say, and trying to explain that reduction in clinical events could be what we are doing locally in the different plaques in a systemic way. So thank you very much for your experience and your clarity. And something else that you want to finally tell the audience?
Well, I think what is very important is for us to be able to have a multifaceted approach to this disease that is clearly not so simple. And so in order for us to have a success in the future, we will need to identify which drug to give to which patient, because we need some ways to identify the efficacy of a drug on a given patient on the basis of their biology, deciding that a given patient might need extra LDL reduction and some other patient needing extra anti-inflammatory drugs, for example, or some people might have even HDL raising or functioning drugs that would be helpful. So we need to find a way through specific biomarkers and target the right therapy for the right patient. I think that would be the target.
Very clear. Thank you, Philippe.
Pleasure. Thank you for the
Thank you.
opportunity.
Bye.